Let's discuss about the electrical activity of the heart. So, as we all know that is consists of two types of tissues. One is the cardiac conduction system and another one is the cardiac muscles. Cardiac conduction system is unique because it has a property of auto-excitability. That's why cardiac system, the heart is a self-sufficient organ because it generates its action potential by own. Now, cardiac conduction system consists of SA node. Then we have this internodal atrial pathways. Then we have this AV node. Then we have this bundle of His and Purkinje system. And bundle of His divides into bundle branches, left bundle branch and right bundle branch. So first of all, will discuss about the SA node. The SA node is the pacemaker of the heart. Why it is the pacemaker of the heart? Because it generates the action potential at the highest rate, that is 70 to 100 per second per minute. Then we have these internodal atrial pathways which conduct the impulses from SA node to AV node. Then we have this AV node which is situated in the left lower part of RA. SA node is situated in the right upper part of RA at the junction of SVC and RA. At the point where AV node ends, it continues as bundle of His, which divides into right bundle branch and left bundle branch. Okay. Right bundle branch goes towards the right ventricle side and then further divides into the Purkinje fibers, which supplies the ventricular muscle. While left bundle branch divides into left anterior fascicle and left posterior fascicle. Now left anterior fascicle goes to the anterior and septal side of the left ventricle, while left posterior fascicle supplies the inferior and posterior wall of the left ventricle. Is it clear? So one of the most important thing in this section is we should know that bundle of His divides into bundle branches. These are left bundle branch and right bundle branch. Left bundle branch further divides into left anterior fascicle and left posterior fascicle. And anterior fascicle supplies the anterior and septal section of the left ventricle, and left posterior fascicle supplies the inferior and posterior wall of the left ventricle. Because in the upcoming section, when we'll discuss about the left bundle branch block and right bundle branch block, or left anterior fascicular block or left posterior fascicular block, then this thing will matter in that section. The cardiac conduction tissue consists of all these things, and all these things have a different speed. So SA node has a speed of 0.05 meter per second. Atrial pathways have a speed of 1 meter per second. AV node also have a quite lower speed, due to which there is AV nodal delay, and due to which we have this PR segment in the ECG. Which is the isoelectric segment. Then we have this bundle of His. Then we have this Purkinje system, which has a higher speed. So Purkinje system supplies the ventricular muscle, and due to which, since the Purkinje system is having the highest speed, the QRS complex is narrow. The normal QRS complex is narrow. Okay. Then this ventricular muscle has a speed of 1 meter per second. Now, what is ECG? So ECG is the record or the fluctuations in potential during a cardiac cycle. Okay. Since body fluids are the good conductors, so the fluctuations in potential representing the algebraic sum of the action potentials of myocardial fibers can be recorded extracellularly. Okay. So basically, since body fluids are the good conductors, so that due to which action potential in the heart can be recorded extracellularly. Now, let us come to the leads in the ECG. So we have majorly these limb leads and chest leads in ECG. Limb leads are 1, 2, 3, AVL, AVR, and AVF. In chest leads, we have this V1 to V6 chest leads. These are the major chest leads. Then we can also have V7 to V9 that we'll discuss later. And we can also have this RV1 to RV6. These are some additional chest leads. So limb leads are the XY plane leads, while the chest leads are the YZ plane. This is also known as frontal plane leads. Clear? Leads can also be divided into unipolar leads or bipolar leads. So unipolar leads are the leads in which the active or exploring electrode is connected to an indifferent electrode at zero potential. So we have only one exploring electrode and the another electrode is an imaginary electrode which is connected to a zero potential. While in bipolar leads, we use two active electrodes. And what is the rule of the graph of the ECG? The rule is when depolarization is moving towards an active electrode, it produces a positive deflection, while when depolarization moves in the opposite direction, it produces a negative deflection. So this rule will be quite helpful when we'll discuss the ECG. Now we'll discuss about the limb leads. They're very important. Suppose this is the heart. Normal heart lies in the mediastinum and it is more towards the left side. Okay. Action potential starts from this SA node, go towards this AV node, and then it will spread into the ventricular muscle. And since ventricular muscle of the left side is more thicker than the right side, so it is more towards depolarization is more towards the left side. This is from the first year physiology part, so we'll not discuss more detail about this. So from this diagram, we know that heart is lying towards the left side, and also the action potential goes from upper end of the body to the lower end of the body. Okay. So most of the leads are made in this way that the action potential and the direction of the leads are in the same direction, so that the recorded ECG will be in upward direction. Okay. So our aim was to keep the action potential, keep the leads of the ECG in the direction of the action potential, so that the recorded ECG would be a upward ECG rather than a downward ECG. Okay, just take the blank page. This was our heart. Basically, if we consider the ECG leads as the cameras looking into the heart, so first of all, we developed this lead 2. And lead 2 is the best lead of the ECG because it is just in the direction of the axis of the heart. Okay. So we have developed this lead 2 in which negative electrode was placed at right upper limb and positive electrode was placed at left lower limb. Clear? So our aim was to put the positive electrode towards the lower limb and also towards the left side, so that the recorded ECG would be an upward one, so that the electrodes would be in the direction of the axis of the heart. So this was lead. And we have this lead 1 in which negative electrode is in the right upper limb and positive electrode is in the left upper limb. So this was also in the direction of the heart, that is towards the left side. Now we have this another lead 3 in which negative electrode is in the left upper limb and positive electrode is in the left lower limb. Clear? So we have developed this 3 leads initially to look into the heart. Then we thought that these 3 leads are looking towards the heart from different directions, so we can develop more leads so that we can look into the heart from more angles also. Okay. So हम ऐसा सोच सकते हैं that these leads are just the cameras taking the picture of the heart from different views. Okay, so we have developed these three leads. After these, we have decided that we can have more cameras to look into the heart toward from more angles. Okay, so we have developed three more leads. How? We have developed a lead perpendicular to lead 1, and this is a unipolar lead. Okay? And this lead is facing in the direction of the foot, so this is known as ABF. Okay? Then we have this lead perpendicular to lead 2, and this lead is looking into the direction of left upper limb, so we called it as AVL. Then we have this lead perpendicular to lead 3, and this is looking into the direction of right upper limb, so we called it as AVR. Okay. Now we have these 6 leads. One peculiarity about one of these leads is that this lead AVR is pointing in the direction of right upper limb, which is completely opposite to the direction of the axis of the heart. Okay. So due to this, all the waves in ECG of lead AVR are negative. Okay. Because AVR points to the direction that is opposite to the direction of the axis of the heart, due to which all the complexes, all the waves in the lead AVR are negative. So these limb leads we have discussed. Okay. We have, if we'll draw a schematic diagram like this, we have these three leads, lead 1, lead 2, and this is lead 3. Here 60-degree angle here, and we have 60-degree angle. Then we have this lead perpendicular to lead 1. Then we have this lead perpendicular to lead 2. We have this lead perpendicular to lead. This is lead APL. This is lead ABF. This is lead ABR. Yeah. So this is the diagram that we draw for limb leads. We'll see the angle. This angle between AVL and lead 1, this is 90 degree. This angle between AVR and lead 3 is also 90. And this angle between 1 and AVF. Yeah. So this is the schematic diagram of the limb leads. Also, when we have these three leads, lead 1, lead 2, lead 3. This triangle is known as AIIMS triangle. And applying the vector equation to this triangle, lead 2 is equals to lead 1 plus lead. This is known as AIIMS equation. And this is a equilateral triangle. So angle between lead 1 and 2 is 60 degree, and 2 and 3 is also 60 degree. Now let us discuss about the chest leads. So when we have developed these limb leads, these leads are in the XY plane only, that is in the frontal plane. So we thought that we can also put leads in the YZ plane so that we can have more pictures of the heart. Okay. So we developed these 6 chest leads. These 6 chest leads are typical chest lead. We also have some another chest lead that we have discussed, like V7 to V9 and RV1 to RV6. What is the location of lead V1? So lead V1 is situated in right parasternal area, 4th intercostal space. Okay. Then lead V2 is located in left parasternal area, fourth intercostal space. Then we have lead V3. It is situated between lead V2 and anywhere between V2 and V4. Lead V4 is situated in fifth intercostal space in mid-clavicular line. Lead V5 in fifth intercostal space, anterior axillary line. And we have lead V6 in fifth ICS, mid-axillary. So these are the 6 important chest leads. Clear? Now, if we'll draw a diagram, suppose this is the sternum, this is lead V1, this is V2, and these are on the left side. Okay, lead V3 to V6 are on left. This is right side of the body, this is left side of the body. So this is V1, V2, this is V3, V4, 5, and beyond this V6. Okay. Now, if we want to look at the posterior wall of the heart, so we have 3 more leads behind V6, that is V7, V8, V9. Okay. They look at the posterior wall of the heart. And if we want to look on the right wall of the heart, we have lead RV1, RV2. RV1 is in the position of the lead V2 and RV2 is in the position of lead V1. Then we have RV3 in position of lead V3 but on the right side, RV4 in position of lead V4 but on the right side, RV5 and RV6 similarly respectively. Yeah. Okay. So we have discussed about these leads, that is lead 1, 2 and 3. If we'll discuss grossly why waves are formed. So P wave is formed because of the atrial depolarization. Suppose this is the heart. Depolarization begins from SA node and going towards AV node. So when there is depolarization of the atrium, a P wave is formed. Then there is AV nodal delay due to which PR segment is there. Then we have this ventricular depolarization which is forming the QRS complex, in which first of all there is septal depolarization, and the direction of septal depolarization is from left to right. Okay. Then there is major ventricular depolarization, and lastly there are depolarization at the bases, the direction of which is towards the upward part of the heart. Then there is a T wave which is there because of the ventricular depolarization, and in the end we have U wave which is supposed to be due to ventricular myocytes with long action potential or due to repolarization of papillary vessels. So there are different theories about the U wave, but most accepted concept is these two only. So if we'll discuss grossly how a ECG looks like in lead 2. So this is a heart. Lead 2 is this. First of all, there is depolarization of the atrium, and the direction of depolarization is in the direction of lead 2. So we have this positive P wave. Then this is PR segment because of AV nodal delay. Then we have this septal depolarization which is in direction of left to right. So it is a downward deflection in lead 2 because it is in direction opposite to that of the lead 2. Then we have this R wave in lead 2 because of major ventricular depolarization which is in the direction of lead 2. And we have this depolarization of the base region which is in direction opposite to lead 2. We have this S wave due to this. Then we have piezoelectric QT segment. And we have T wave due to repolarization of the ventricles. Okay. If we'll discuss about the direction of depolarization, so direction of depolarization is from endocardium to epicardium. Reason being that The conduction tissue, that is Purkinje fibers, bundle of his bundle branches, are located in the endocardium region only. Okay. And repolarization direction is from epicardium to endocardium. These things we'll discuss. Yeah. Now we'll discuss about ECG sheet or ECG paper. This is a very important. Okay. So ECG paper moves with a speed of 300 large squares per minute, or we can say this as 1500 small squares per minute. So this is a large square of a ECG paper, okay, in which there are 25 small squares, 5 small squares horizontally in a horizontal line and 5 small squares in a vertical line. Okay. And each small square is of 1 mm length and 1 mm height. Okay. So ECG paper moves with a speed of 300 large square per minute, or we can say 1500 small squares per minute, because one large square contains 5 small squares. Okay. Now time duration. Now we know that 1 minute there are 300 large squares. So one large square would be of 0.2 second, and one large square contains 5 small squares. So one small square would be of 0.04 second duration. Strongly written 0.04 seconds. From the main topic of discussion, interpretation of the ECG. First of all, we'll not diagnose or make diagnosis by looking at ECG directly. Okay? We'll interpret these 10 points first in all the ECG that we'll look at. In this way, we'll not miss any sign or any important diagnosis. Okay. So these are 10 things, and we'll look into them successively. Okay. So first of all, we'll look at the rate, then rhythm, then axis, then P wave, then PR interval. After that, QRS complex, ST segment, QT interval, T wave, progression of R wave in chest leads. And lastly, we can also look at if U wave is present or not. Clear? So first of all, we'll look how to calculate a rate from an ECG. So now we know that ECG paper is moving with the speed of 300 large squares per minute. Here. So from an ECG, we can see that, well, this is the ECG. This is the RR interval. Okay. Up, if this RR interval, the distance between these two RR is 3 big squares. So the rate is 300 by 3, that is 100. Okay. So rate can be calculated by this formula, 300 upon R interval in terms of large squares. Okay. Or rate can also be calculated as 1500 upon RR interval in terms of small squares. Clear? If the heart rate is less than 60, then we called it as bradycardia. And if it is more than 100, then we called it as tachycardia. So first thing to look into an ECG is the rate. Okay. Second thing that we look in an ECG is rhythm. So in rhythm can be regular or irregular. When we call the rhythm as regular is when the RR interval is same. Okay. Suppose this is the ECG, one QRS is this, second is this, third is this, fourth is this, and RR interval is same in all these complexes. And irregular rhythm is when the RR interval is variable. Okay. Suppose this is one QRS, the second QRS is this, third is this, fourth is this, fifth is this. Okay, so this RR interval are variable. This is known as irregular rhythm. Now, in most of the pathologies, we have the regular rhythm in ECG. Only three conditions would be having an irregular rhythm. One is atrial fibrillation. Another one is multifocal atrial tachycardia. Third one is atrial flutter with variable AV block. Okay. We'll discuss in detail about these three things in the upcoming classes. Okay. Let us look into one of the images. So this is an ECG in which this RR interval, this RR interval, this RR interval, and this RR. All of these are variable. So rhythm here is irregular. This is the ECG of atrial fibrillation, which we'll discuss in upcoming classes. Then third thing to look in an ECG is axis. Okay. So for axis, we only need limb beats. Okay. And this is a very important diagram that we need in finding the axis of the heart that we have drawn in previous section. So this was lead 1. This was lead area. So we would be needing only 2 or 3 leads for finding the axis of the heart. Okay. This is lead 1. This is lead area. This is 0 degree. This is 90 degree. This is 180 degree. This is minus 90. First of all, we should know what is the normal axis of the heart. The normal axis of the heart is minus 30 degree to plus 100 degree. And for all practical purposes, to make our lives easier, we consider is at minus 30 to plus 90 degree to make the calculation easy. Okay. So this is minus 30 and the lead at minus 30 degrees lead area. This is plus 90 degree. This region is the normal axis of the heart. This is because the muscle of left ventricle is thicker than the right ventricle. So our heart's axis is more towards the left side normally. This region from minus 30 to plus 90, this is left axis deviation. Then this area from plus 90 to plus 180. This is right axis deviation. And finally, this area from minus 90 to 180 is extreme axis deviation, or it is also known as northwest axis deviation. Here. Now how to find the axis of the heart? We have these two leads, lead 1 and AV. So we will look at these two leads only. If QRS complex in lead 1 is positive and lead AVF is also positive, then what is the axis of the heart? Okay. So first of all, how to come to know that the QRS complex in lead 1 is positive and AVF is positive? So suppose this is a QRS complex. So it is clear that this is a positive QRS complex. But suppose this is one of a QRS complex. Then how will we come to know that this is a positive QRS complex or a negative QRS complex? So for these type of QRS complexes, we have this formula R minus S minus Q. Okay. If R minus S minus Q is positive, then it is a positive QRS complex. If it is negative, then it is a negative QRS complex. So suppose in this QRS, Q wave is of 4 mm, R is of 10 mm, and S is of 5 mm. Okay. So this is 10 minus 4 minus 5, 1 plus 1. So this is positive QRS complex. Okay. Now what is the axis if lead 1 is positive QRS complex and in lead AVF there is also positive QRS complex. Since lead 1 is positive, that is the QRS complex in lead 1 is positive. So axis would be in this hemisphere. Okay, so if axis would be in this hemisphere, then only lead 1 can show a positive QRS. Now, since lead AVF is also positive, so axis would be in this hemisphere, then only lead AVF can be positive. Clear? So overlapped region is this, means axis would be from 0 to plus 90 degree, and that would be a normal axis. Clear? Now second scenario. Second scenario is lead 1 is negative and lead AVF is positive. Clear? So if the QRS complex in lead 1 is negative, axis would be in this hemisphere. That is the hemisphere opposite to lead 1. Okay. And since QRS in lead AVF is positive, axis would be in this hemisphere. So the overlapped region is this, and so the axis would be from plus 90 to 180, which is right axis. Clear? Third scenario, lead 1 is having negative QRS and AVF is also having negative. In this scenario, this is lead 1 support, this is lead AVF. Since lead 1 is negative, axis would be in this hemisphere, and since lead AVF is also negative, axis would be in this hemisphere. So overlapped region is this, so the axis would be extreme axis. Clear? Fourth scenario. Till now we have seen that we can derive the axis of the heart by looking at only lead 1 and AVF. Now the last scenario is lead 1, this is AVF. Now this scenario is lead 1 is positive and lead AVF is negative. In this scenario, since lead 1 is having a positive QRS, axis would be in this hemisphere, and AVF is having a negative QRS, so axis would be in this hemisphere. So overlapped region is this. Now till minus 30, this can be a normal axis, and from minus 30 to minus 90, this can be left axis deviation. So for this scenario, we would be needing one more lead, that is lead 2. The lead perpendicular to minus 30 degree. Okay. Now, if lead 2 is having a positive QRS, then axis would be in this hemisphere. And the overlapped region of all these three would come out to be this. That is 0 to minus 30. So the axis would be normal. While if QRS in lead 2 is negative, overlapped region would be so exit would be from -30 to -90, that is left excitation. So this is the only scenario in which we would be needing lead 2. Otherwise, in all other conditions, we would be needing only lead 1 and AVF for access. Clear? In upcoming classes, we will discuss about the causes of left axis deviation, causes of right axis deviation. Then fourth thing to look in an ECG is P wave. P waves. For P waves, we majorly look at lead 2 and lead P1. This is hard. Lead 2 is this. Okay. Depolarization of atrium start from SA node, goes towards AV node and towards LA. Really? So in lead 2, P wave is a positive deflection, which is less than 2.5 mm or 2.5 mm small square in width and less than 2.5 mm small square in height. Clear? So this is a normal P wave in lead 2. If we divide it, so this portion is for RA depolarization and this is for LA depolarization. Okay. Similarly, in lead V1, since lead V1 is somewhat here and it is in YZ plane, SA node fires and there is depolarization of RA and LA. Since LA is the posterior most chamber of heart, so depolarization seems to be going from away from V1 during LA depolarization. Okay. So in lead V1, there is a biphasic P wave. That is, upward deflection is because of RA depolarization, and downward is because of LA depolarization. And in this biphasic P wave, upward deflection is of less than 1 mm width and less than 1 mm height. Also, downward deflection is also less than 1 mm width and less than 1 mm height. Clear? Now, pathology of P waves. So, in lead 2, P wave is like this: RA, L, less than 2.5 mm or less than 2.5 small square width, less than 2.5 mm or less than 2.5 small square height. Okay. Now, suppose there is this RA enlargement. Okay. Since there is RA enlargement, when the SA node fires and there is depolarization of RA going, in the same time LA also depolarizes. Okay. So most of the time there is RA enlargement, then LA enlargement. So RA depolarization and LA depolarization. Okay. But in this scenario, RA and LA get depolarized at the same time because जितने टाइम में ऐसे नॉट फायर करके आरए को डिपोलराइज करेगा उतने टाइम में वो एलए को भी करके आ जाएगा बिकॉज ऑफ आरए एनलार्जमेंट. सो आरए एनलार्जमेंट में in lead 2 we have this tall P wave. Width of the P wave would be same, that is less than 2.5 mm. Why? Because the later half of the time of P wave is because of LA depolarization, and since LA is of normal size, the time would be same, but height would increase because now LA and RA would depolarize at the same time. Clear? So height would be now more than 2.5 mm in lead 2. So if the height of P wave is more than 2.5 mm in lead 2, it suggests RA enlargement, which is also known as P pulmonale, because most common cause of RA enlargement is pulmonary hypertension. Here, now suppose there is this LA enlargement. This is a normal P wave in lead 2. Now since LA enlarges, RA get depolarized early, but LA would take more than normal time to depolarize. So there is this broad P wave. And there is a notching here in P wave which is known as bifid P wave. Okay, so this would be a broad bifid P wave. Width would be more than 2.5 mm, while height would remain normal, that is less than 2.5 mm or 2.5 small square. Okay. So broad P wave in lead 2 suggest LA enlargement, which is also known as P material. So the most common cause of LA enlargement is either MS, multiple or mitral stenosis, or MR, that is mitral regurgitation. Clear? Now in lead V1, suppose there is LA enlargement. So the normal P wave in lead V1 is like this, with biphasic, with height less than 1 mm and depth is also less than 1 mm. So suppose there is LA enlargement, the depth would increase, that is the downward deflection would increase and it would become more than 1 mm. While if there is RA enlargement, the upward deflection would increase, that is it would become more than 1 mm. Clear? So if there is RA enlargement, then upward deflection would increase by more than 1 mm. If there is downward deflection, then if there is LA enlargement, the downward deflection would increase and the size would become more than 1 mm. Okay. Till now, we have looked 4 things in ECG, that is heart rate, rhythm, axis, P wave. Now, fifth thing to look in an ECG is PR interval. PR segment is because of AV nodal delay. Normal PR segment is less than 2.5 mm or less than 2.5 small squares. PR interval is P wave plus PR segment. So it is less than 5 mm or less than 5 small squares. There. Now, normal PR interval is less than 5 mm or less than 5 small squares. If there is increase in this PR interval, it suggests heart blocks. Okay. We'll discuss AV block in upcoming section. That is, AV blocks are of 3 types: first degree, second degree, third degree. Okay, so one thing common in all these things is increase in PR interval. PR interval can be decreased in WP syndrome. That is, there is an accessory pathway which is bypassing the AV node. Okay, so there is no AV nodal delay leading to shortened PR segment, leading to shortened PR interval. Okay. Now, sixth thing that is we are looking in an ECG is QRS complex. QRS complex is due to ventricular depolarization that all of us know. Normal QRS complex is less than 2.5 to 3 small squares. That is 0.10 to 0.12 seconds, because one small square is of 0.04 seconds. If QRS complex is more than 0.12 seconds or more than 3 small squares, then we call it as broad QRS. There are various causes of broad QRS complexes that we'll discuss later. Okay. Now look at this ECG. We can clearly see that QRS complex here is equal to 5 small squares. That is 0.2 seconds. So it is a broad QRS. In this ECG also, QRS complex is somewhere around 4 small squares. So it is also broad QRS. There are various causes of broad QRS that we'll discuss later. But these two ECGs are of hyperkalemia, which is also one of a cause of broad QRS. Okay. Seventh thing that we are looking in an ECG is ST segment. Okay. So ST segment is generally an isoelectric segment, and it represents repolarization phase only. Okay. Now ST segment is very important component because it elevates or depresses in various pathologies. What are the causes of ST segment elevation and depression? The most important cause is ST segment elevated MI. It can also be elevated in pericarditis, the cardiomyopathy, LV aneurysm. And ST segment depression can be because of reciprocal changes, non-ST segment elevated MI, and various other causes. There are also other causes of ST elevation like repolarization anomalies, which we'll discuss later on. Okay. So, which ST elevation is called as significant ST elevation in case of STEMI. Okay. So, first of all, this is a QRS complex. This is ST segment. So this point is known as J point. That is junction of QRS and ST segment. Here. So in case of STEMI, ST elevation more than 1 mm in two anatomically contiguous. Anatomically contiguous means the leads which are representing the same wall only. Okay, so lead 2 and 3 are contiguous because these represents inferior wall, but lead 1 and 3 are non-contiguous. Similarly, lead 1 and AVL are contiguous because these are representing the lateral wall. Okay. We'll discuss more detail about this section. So ST's elevation more than 1 mm in two anatomically contiguous leads. Two or more. Okay. Except lead V2 and V3. So for lead V2 and V3, ST segment elevation should be more than 2 mm in case of males more than 40 years. In case of males less than 40 years, ST segment elevation in lead V2 and V3 should be more than 2.5 mm. While in case of females, ST segment elevation in lead V2 and V3 should be more than 1.5 mm. Here. Now, in lead V7 to V9, that is the leads of the posterior wall, ST segment elevation more than 0.5 mm is significant. In leads RV1 to RV6, that is the posterior wall leads, right wall leads, ST elevation more than 0.5 mm is significant, except in males less than 30 years, ST elevation more than 1 mm is significant. Now ST depression. So if there is ST depression of more than 0.5 mm in all leads, so this is 1 mm. More than 1 mm in all leads except V2 and V3, in which ST depression is more than 0.5 mm. then it is significant ST depression for Einstein. Clear? Now, eighth thing is T wave. Okay, so T wave represent repolarization of ventricles. They are considered tall when they are more than 5 mm in limb leads or more than 10 mm in chest leads. Tall T waves are associated with hyperkalemia and hyperacute stem, like we have seen in this ECG. No? This is an ECG of hyperkalemia. So we have this broad QRS. Also, there is this large T wave here. Clear? Also, we can have these T wave inversions, okay, that we'll discuss in upcoming section. Ninth thing that we look for in an ECG is QT interval. Yes, so QT interval comprises of QRS complex plus ST segment plus T wave. QT interval is a very important component because QT interval contains ST segment and T wave, which represents repolarization. So if QT interval is prolonged, the repolarization is prolonged. And if repolarization is prolonged, there are more risk of ventricular tachycardia. Clear? Now, prolonged QT interval leads to ventricular arrhythmia, which is known as torsades de pointes or polymorphic ventricular tachycardia. Now, if heart rate is more, QT interval would decrease, and if heart rate is less, QT interval would increase. So we need to have a ratio that would neutralize the effect of heart rate on QT interval. So we use this QTC, that is corrected QT interval, which is calculated with the help of this Bazet formula, that is QTC is equals to QT interval upon under root of RR. Now, if this QTC is more than 0.44 milliseconds in males or more than 0.46 second in females, then it is QT prolongation. Now, the causes of QT prolongation can be congenital or can be acquired due to drugs like erythromycin, hydroxychloroquine, amiodarone, or electrolyte abnormalities like hypokalemia, hypocalcemia, and hypomagnesemia. Okay. Now, by grossly looking at an ECG, how to calculate the QT-C interval. So, suppose if this is only valid if heart rate is more than 70. So if heart rate is more than 70, this is one R wave QRS complex, this is another, this is T wave. So if heart rate is more than 70 and QT interval, it is this, is less than half of RR interval, then it excludes QT prolongation. Okay. And if QT interval is more than half of RR interval, then either it can be normal QT or prolonged. So by grossly looking at an ECG, we can suspect that there is QT prolongation or not. Then the 10th thing to look in an ECG is progression of R waves in chest leads. Okay, so this is a heart. This is lead V1. This is V2, V3, 4, 5, 6. V1, V2 are known as septal leads and they are more towards the right side of the heart. V3, V4 are known as anterior wall leads and V5, V6 are known as lateral wall leads. Normal axis of the heart is normally in this direction. So the major ventricular depolarization direction is more towards V4, V5, V6, and V1, V2 are opposite to that. Okay, so QRS complex normally in lead V1 is first a small wave R wave due to septal depolarization and a big downward S wave due to major ventricular depolarization. Similarly, in lead V2, we have this R wave due to septal depolarization and S wave due to ventricular depolarization. Okay. Similarly, if we keep on going towards V3, V4, V5, V6, so in V3, the R wave would keep on increasing and S wave would keep on decreasing. And in V5 and V6, there is a R wave and can be a small S wave present there. Okay. In lead V5 and V6, we can have this small Q wave initially due to septal depolarization and a big R wave, a small R, S wave. So this is normal progression of QRS complex. So in V1, we have this small R and big S. V2, R wave would increase. V3 and V4 are transition zone, that is R and S would become equal almost. Then V5 and V6 are in which there is a big R wave and a small S wave. The Q wave can also. This is normal progression of R waves. In some of the pathologies, this normal progression of R waves doesn't occur. It can be because of clockwise rotation. It can be because of ECMP and a lot of pathologies that we'll discuss later. Thing that we can also look in ECG is U wave. So normally U waves are so small that they are difficult to look in an ECG. But if they are there, they are best seen in lead V2 and lead V3. And they are generally smaller, very smaller than T waves. Okay. But in pathological conditions like hypokalemia, U waves size increases and they are almost equal to T wave. Clear? So we have seen that ECG interpretation will look at these 11 things. So in sequential manner, we'll look at these things. First is rate, second is rhythm, third is axis. Clear? Then we'll look at P wave, then we'll look at PR interval, then we'll look at QRS complex, then ST segment, then T wave, then QT interval, progression of R wave in precordial lead, and a U wave. So this class was about basics of ECG. In upcoming sections, we'll discuss about the pathologies, different pathologies, detailed explanation of different pathologies, their ECGs, how to diagnose them, and their treatment. Okay.